Our next speaker is Dr. Dan Hurley.
So, everybody hear me okay? When I thought sore throat in 15 to 17 minutes, I said, great, this is a huge topic, how are we going to cover it? And then I started thinking about it, I said, well, actually, you could do this every day in 15 minutes with the person who comes through thinking they have cancer because they're on the internet. So we're going to go through kind of how I approach sore throat when I walk into the room. I don't have any conflicts of interest. We'll review the differential diagnosis and go over what I use as a strategy, as well as going over some red flags that are going to kind of make you send them to us a little sooner. And then assuming we don't run out of time, we'll go over a case because that's how I learn the best. So when I'm thinking about this, I classify it as acute versus chronic. You see more of the acute sore throats than we do because they just don't get to us. Then the chronics end up in our office, a few months after it starts. I always go back to the old infectious, inflammatory, neoplastic, congenital because it just helps classify everything. More or less worrisome characteristics, and what's the patient really here for? Are they here for treatment, or do they just want to be reassured? So when I split them into acute versus chronic, could be 3 weeks, could be 4 weeks, I use 4. And we go down the left side of the screen, and most of those are going to be infectious. Most of those are viral. They can be bacterial. It could be their throat. It could be a sinus. It could be a dental issue. Occasionally, it could be a congenital neck mass that's inflamed. And it could be inflammatory, but those are going to pop out at you with history, recent intubation, trauma, et cetera. And then more than 4 weeks, inflammatory bumps to the top of the list. Most commonly reflux, allergies, any number of things. Rarely autoimmune. When you get to infectious, now you're thinking of different things than what they normally will pop into the office with. Maybe it's a prolonged EBV or CMV. Maybe it's thrush, mycoplasma, occasionally pertussis, and then sinusitis, tonsil stones, and then down at the bottom, neoplastic, which is, by the time it gets to be a chronic sore throat, what most people are worried about but don't actually have. So in acute infectious, majority of those are viral, as everyone knows. Cough, rhinorrhea, hoarseness, ulcers, conjunctivitis. Mono and CMV are not the most common. They're just the most impressive when they present acutely. And then, of course, the infectious bacterial group A strep gets all the press, probably more than it deserves. Of all the people that show up, you can't hear me?
Put it on.
Oh. Of all the people that show up with a sore throat, 5 to 15% of adults will actually have group A strep, 20 to 30% of kids. And then there's the central criteria. They say strep doesn't have a cough, although my wife's a pediatrician said, they all do, so you can take that for what it's worth. The most common risk factor for strep is contact with someone. So why and how do we treat strep? Because it always seems to me that people end up, okay, you got cultured, you don't have strep, you don't have anything else, off you go. Well, the main reason we treat it is to prevent transmission. That's one, but is to prevent complications of rheumatic fever, which are rare. Those are most common in that 3 to 15 group. So they're the ones we need to focus on. We want to reduce transmission. It shortens the duration of symptoms, although people will get over strep and probably do all the time without actually being treated. There are no documented cases of penicillin resistance, so we don't need fancy antibiotics. In fact, if you're using non-penicillin, you have to up the dose. And then if you're treating non-strep, presumed bacterial, that's when you actually broaden your antibiotic spectrum. So, clinical decision to treat. This is something that we probably do as otolaryngologists more frequently because by the time they get to our office in an acute setting, they have a more severe problem. But remember, strep's not the only bacteria that causes pharyngitis. Diagnostic accuracy of cultures is limited because we can culture anybody's throat in this room and grow a whole bunch of stuff. It doesn't mean we need antibiotics. And then, so severe symptoms, referred pain to the ear, sick kid, I'm more likely to say, okay, let's put you on 1, steroids, and 2, antibiotics. So these are 3 pictures where I'd say, I'm going to treat all 3 of those. The top one, I'm thinking mono, so I might just do steroids and give them antibiotics to fill in a couple of days. The bottom 2, I'm worried about, but we'll have that in a later panel. Moving more to the chronic sore throats, candidiasis. This slide does not transmit as well as I'd like. but maybe on the TVs. It can have an atypical appearance. We all know what Candida looks like with the little cotton, and that's easy to treat and diagnose. But when you have that older person who has dentures, who wears a mouthpiece, especially if they've been on antibiotics and prednisone, just with a kind of chronic sore throat, and they have that shiny tongue, it's worth just trying them on nystatin if you can't find anything, because you'll get benefit more often than you think. Now, if the nystatin happens to work, you're probably going to need diflucan for 10 to 14 days, because candidiasis in the oral cavity is just difficult, and if they have dentures, they gotta soak them, do something to them, because they always tend to reseed. Tonsil stones typically don't cause a sore throat, but they're worth thinking about. These are the foul-tasting little rocks in the back of the throat. Basically, the tonsils have crypts. They trap food and debris, and bacteria loves that stuff. It's a low-grade chronic tonsillitis. Treatment is based on the severity of the problem. Rarely do they need antibiotics, but if it's a recurring problem, and my statement to everyone is, do you have a bad enough problem that you want to trade a week to 10 days, the worst sore throat of your life, to get rid of this forever? Because if you take the tonsils out, it'll stop. But reflux laryngitis. So in chronic sore throat, if you don't know what the problem is, it will be reflux more often than not. And the most challenging problem is convincing the patient that it might be that. So intermittent discomfort, fluctuating raspiness to the voice, worse in the morning, history and lifestyle, empiric therapy versus dual pH probe. I usually talk about the dual pH probe and describe it to them to get them to try empiric therapy. And then it's, I already said, it's most common. If you don't know what it is, it's worth a trial of Pepcid or Zantac, and except for Zantac just got pulled. Allergies and sinusitis, not a common cause of isolated sore throat in my practice, but you think about it. And if you think it might be allergies, they have that clicking in the throat. I like Astelin. Dr. Rubin laughs at me because I love Astelin for everything, but it's worth a try, and if it helps, great. If the patient thinks it's sinusitis but you don't, you can treat them, but I'm biased more towards proving it if I get to that. CT has a very high negative predictive value, but is rarely necessary. Chemical irritation. So this happens more commonly, and it's historical, and it's usually, I started with a virus, most common being, now I'm using cough drops. Well, how much are you using? Using a half a bag a day. Well, stop it, you're cured. And then obviously vaping, smoking, alcohol. I always love the old posters that show that Lucky Strikes are the physician's favorite. But muscle tension dysphonia. Not a common cause, historical diagnosis, but you have to keep it in mind. I always picture Bill Clinton. I don't know if he really has it or not, but if you hear his voice, he presses, and you can just hear him using his accessory muscles. And these are typically public speakers. They'll say, my throat hurts at the end of the day, often started with a viral upper respiratory infection, and then the viral upper respiratory infection gets over, but they push through it, for example, a teacher, and now they've got to modify. Voice rest will sometimes get rid of it. Occasionally they need to see speech pathology. Neoplasia. This is what everybody's worried about. These two slides obviously are not going to be a diagnostic challenge. Squamous cell is the most common. HPV's exploded. Lymphoma can occur as well, of course. The thing you have to worry about is unilateral symptoms. Referral ups your level of interest or concern. So, red flags. Airway concerns, unilateral symptoms, referral ear pain in the setting of acute pharyngitis, or ear pain in the setting of a chronic sore throat. Both warrant a little higher index of suspicion. And then obviously can't swallow, you're coughing up blood, your voice is changing, those speak for themselves. And then if it's progressing for more than 4 weeks, certainly worth a look. So this is the case. This is an actual HPI that I just lifted when I was thinking about this talk. So I'm going to read through it briefly, but you see these every day. So a 50-year-old with a gradual onset over months of soreness in the throat. She points to the hyoid area. It's variable in severity. No exacerbating or alleviating issues. No environmental changes. No new pets. Nothing in the house. No medication changes. No dysphagia. No hemoptysis. Intermittent ear pain, but she doesn't relate it to the current symptoms. no chronic eustachian tube dysfunction, occasional globus or feeling the food hangs up with no regurgitation, stress levels higher last year, family member with cancer, dinner at 6, bed at 10, 1 cup of coffee, 2 glasses of wine, social smoker, quit a year and a half ago, no weight loss, no recent dental or TMJ, tonsils out as a kid, no known thyroid issues or recurrent pharyngitis. And that was my HPI for that person. First, before I even do anything, I'd say, okay, she's just worried she has cancer. And I bring it right out. I'm like, why are you here? And you just pull it out of them because you might as well discuss it. And if she has a problem, it's probably that she has a little reflux or whatnot. So when I evaluate that person, what do I do? First, the history means more than anything. Second, not everyone wants or needs to be treated. If you can identify lifestyle factors, they can modify them, and that's maybe all they want is a few pointers and to know that they don't indeed have cancer. Third, exam. And I talk to them about, okay, we can look at the outside, we can look at the inside, and we can look in between. And when do we want to do that? With the exam, don't be shy. They think they have cancer. Get your finger back there. They're going to gag, they won't like it, but feel their tonsils, feel the back of their tongue. They'll walk out happier knowing they've had a thorough exam, and you'll be more likely to pick up the tonsil cancer or base of tongue cancer because you have a frame of reference. Direct visualization, that's a nasopharyngoscope. Usually that means they've made their way to our office. And then imaging, ultrasound, CT, and MRI. Imaging is rarely needed on the first go round. Obviously, if they're a smoker, high index of suspicion, you're going to do more cross-sectional CT or MRI. Ultrasound's a great tool when the exam's negative, but they don't believe you, and you just want to give them a test to tell them, look, you're okay. And then empiric treatment to assign causation. And this is important for 2 reasons. First, in the person that has a problem that wants to be treated, you want to make their problem go away. And second, in the person where you have a little higher index of suspicion, let's say your exam's completely negative, but they are a smoker. Well, I want their symptom to go away. Otherwise, I'm going to look further and make sure I'm not missing anything. And most commonly, that's a month of reflux therapy. But if you're suspicious for something else, go that route. That's what I have. So thanks for your attention. I'm happy to answer a couple of questions if you like.